and it's a pleasure to speak to you all today. I'd like to share with you some things that I think might be relevant, at least hopefully helpful for you in your practices. So thank you for joining. All right. Well, as Amy said, we're going to talk about understanding the connection between infections, our immune system, and the brain. I'll share with some case studies and also a little bit about the biology so that you can have a broader perspective of really what I believe is a area of medicine that is going to radically transform how we view and how we treat and diagnose many chronic disorders that you've probably been involved with in treating. So with that, we're going to go over the background of how infections can trigger neuropsychiatric symptoms, and then we'll talk about why certain infections can trigger an immune-mediated neuropsychiatric disorder such as PANDAS, PANS, neurologic Lyme, maybe even long COVID, and even several other types of symptoms. And then we'll show some case studies on patients before and after treatment, how their profile, their panel results, and what these antibodies are directed against, and how they actually can interfere with certain types of biological activities and manifest in certain types of treatment. And then at the end, we'll go through some symptom correlation with these biological targets in what we call the autoimmune brain panel, which are 5 targets that we'll talk about here in just a second, and then how they can be helpful to you as you look for aids in your diagnosis and directing treatment and even follow-up. So as Amy said, if you had any questions, feel free to leave them in the chat. We'll work to try to get as many of these as possible before the end of this session. So let me start by just showing that we all know that infections such as strep, Borrelia burgdorferi, mycoplasma, even SARS-CoV-2, viruses such as EBV, CMV, HHV6, etc., all have the ability to affect the body and cause neuropsychiatric symptoms, cardiovascular symptoms, pain, fatigue, cognitive brain fog symptoms through a direct effect. When I say direct effect, what I mean is the infectious agent is actually the causative agent and is actually impacting these different parts of the body, and they are actually the cause, and the treatment is eradicating these infections. But what I want to talk to today is what I believe is probably a more prevalent component of what really happens in more cases than this, is this indirect effect. And that is the ability of these infectious agents to confuse the immune system such that it mounts a response against these different areas of our body and cause these symptoms that are in some cases, in most cases, resistant to standard treatment, but also then are responsive to treatment that are directed against the underlying immune dysfunction, whether it's inflammation, whether it's immune dysregulation, and of course the infection that's triggering it. So let's start out with the problem. We know that worldwide there are hundreds of millions of individuals who suffer from various types of neurologic, psychiatric, and behavioral disorders. And the list is quite long. Here's a handful of them that you're familiar with. Autism, eating disorders, PANDAS, PANS, anxiety disorders, ADHD. All of these disorders are currently diagnosed by clinical symptoms and not biology. So the definition for Tourette's is motor or vocal tics for more than 12 months. But it doesn't really tell you the biological underlying causative reason for this, and therefore the attempt is trying to treat symptoms. And what we find, though, it's in that based upon the different category of diagnoses, between 20 to 60% of these patients are labeled as treatment resistant. So why is that the case? Well, we know that standard of care for neuropsychiatric disorders and mental illnesses focuses on, as I mentioned, treating symptoms, and sometimes it's even said just to be able to cope. And so the standard of care is treatment with psychotropic drugs. And there is about 60 million individuals in the United States who are on many of these psychotropic drugs, of which many of them are doing some really amazing and fantastic things to help large populations of patients be able to actually return to some sort of normalcy in life. However, as I mentioned, there's a large percentage that they are treatment resistant. And on top of this, we do know that there are deleterious side effects and warnings for these different psychotropic drugs. If that doesn't work, often psychotherapy might be used in conjunction. And then lastly, if none of these work, the patient may end up, excuse me, institutionalized. So let's start with the question, can infections trigger an autoimmune response that leads to these neuropsychiatric disorders? So JAMA Psychiatry published a study of over 1 million individuals that were followed in Denmark from birth to age 18. And what they found was that if a patient was hospitalized for a severe infection, they found that the association of the risk of developing a mental disorder increased by more than 80%. For what? Well, schizophrenia, autism, OCD, ADD, ADHD, personality, and behavioral disorders, oppositional defiant disorders, tic disorders, and the list actually went longer. So in an editorial, the editors stated, how could exposure to infections affect the brain mechanistically and give rise to mental disorders? What they said was circulating autoantibodies that enter the brain via a compromised blood-brain barrier bind to neurotransmitter receptors, and that's a potential explanation and a mechanism that's been proposed in pandas and other mental disorders. So we know that a large portion of neuropsychiatric disorders can be caused by infection-triggered autoimmune dysfunction. And even COVID or SARS-CoV-2 has shown us that there is a prolonged effect in a certain population of individuals that have experienced these infections in which they'll see immune responses against certain organs of the body, such as the brain, the heart, the lungs, and others, and which we know of as long COVID, or sometimes called PASC, post-acute sequelae of SARS-CoV-2 infection. So how does this occur biologically, which is a really good question here. And we all know that we get in contact with various types of microbes all throughout our life. And our body normally and faithfully produces antibodies that will recognize infectious agents and be able to take care of these infections. And for vaccinations, we get these because we want to at least prepare the body for making these antibodies ahead of time prior to exposure to certain types of very debilitating types of infections. Well, what happens here, and this goes wrong, is a process called molecular mimicry, in which antibodies can cross-react with neurologic receptors. So the antibodies that are made actually are made against a part of an organism that looks exactly like a part of our body. We'll talk about this a little bit more. And in these cases where they're made that cross-react with, let's say, neurologic receptors, they can then cross the blood-brain barrier, as was mentioned in the JAMA Psychiatry article, and they can interfere with normal brain function, as what we kind of think of as friendly fire in the wartime. That results in these heterogeneous neuropsychiatric symptoms because of this antibody interference with these different biological receptors. Patients that are placed on these symptomatic treatments generally are treatment resistant, and often they actually get worse. Whereas when patients are placed on immune modulators, anti-infectives, and anti-inflammatory agents, what we can see is some remarkable recoveries in these patients. We'll talk more about this in some of the case studies. So other articles and journals are showing that there's a recognition of a direct connection between infections, the immune system, and autoantibodies in these psychiatric disorders. Of course, you can see these other areas such as the microbiome, other types of things for chronic inflammation, which we'll talk about in a second, leading to autoimmune disorders. But you can see that there is a connection between these. So there's a difference between acute and chronic inflammation. Acute inflammation is how our immune system responds and puts on alert the rest of our immune system to be able to attack infectious agents or heal a wound or a cut. Whereas infections that actually cause chronic inflammation, meaning inflammation that does not subside or does not resolve, is known to resolve in various types of chronic disorders, such as autoimmune diseases and neurologic diseases. In fact, if you've seen more recent articles, what you'll find is that there's a growing recognition of the connection between infections, the immune system, and Alzheimer's disease and dementia and other neurologic disorders. In fact, the current prevailing belief is now, as you can see from a few of these articles, that Alzheimer's disease is an autoimmune disease and that it's an autoimmune function in which the immune system, as I mentioned, is actually recognizing parts of the body as foreign, and the belief that beta amyloid is an immunopeptide. And this is actually what's being triggered and accumulating in the brain. So one thing that happens as a result of specialization and our reimbursement system in medicine, at least in the US, is that it unintentionally makes it challenging to diagnose and treat complex immune-mediated disorders. So the prevailing model of disease biology is that psychiatry, psychology is practiced separately from immunology, which is practiced separately from infectious diseases and neurology, which is why it's important to have really a practice or an understanding of the integrated view of disease biology, whereas infectious diseases impact and can impact psychiatry, psychology, neurology, and our immunology. And therefore, cross-disciplinary and collaborative medical care can really accelerate the diagnosis and treatment of these chronic disorders, and most of these patients are suffering from these disorders for many, many years, in fact, many decades. So I want to share with you, because we have tested now about 16,000 patients clinically in our autoimmune brain panel from over 50 countries. And what we find is that they end up going in this cycle of being transferred to different specialists. And when they don't find that they're actually being helped by these specialists, they're moved to another specialist. Trial and error medication is given. And on average, what we have found in a burden of care study, that they spend about 3 to 7 years across 5 to 15 providers, in addition to spending 20,000 to 100,000 US dollars on doctor visits, medical testing, and ineffective treatments. We're preparing to publish a study here that does describe what is the financial burden, but some interesting things in some write-ins where patients were writing in what was the consequence of this. You can see that the financial consequence, let alone the medical and the societal consequence, are tremendous, and it's devastating. And I'm sure that you all experience this with different patients. But this is what we want to address in looking at how medicine is practiced for certain types of complex disorders. So I want to introduce, if you haven't, and most of you probably have heard of PANDAS and PANS. This really is not a testing for PANDAS and PANS as much as what we're looking at is an immune-mediated neuropsychiatric disorder. So I want to bring PANDAS and PANS up as a medical model for a whole host of these immune-mediated disorders. And as you may be familiar, the term means pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection, which was coined and identified by Dr. Susan Swedo at the National Institutes of Mental Health. And it was published in the first 50 cases in which in 1998, she described that these patients' sudden onset of OCD and other types of neuropsychiatric disorders that were preceded by a streptococcal infection. So the mechanism of anti-neuronal antibodies interfering with receptors is pretty universal. There are multiple different targets and multiple different antibodies that have been identified, some rarer than others. But what we're going to talk about today is what I believe are some of the top five most common autoantibodies that are involved in a lot of these different types of symptom presentations. So there are studies that show that these antibodies actually attack what's known as the basal ganglia and that they can trigger inflammation in this part of the brain. And so what you can see from this is that the inflammation and what we're looking for here in patients with OCD and tics in the caudate, the putamen, the globus pallidus, whereas not in the thalamus, which is not part of the basal ganglia. There's other research I won't go into that our organization and our team members have published related to showing antibodies directed against the basal ganglia crossing the blood-brain barrier. But one thing is interesting to note is the basal ganglia is responsible for motor control, learning, procedural learning, and cognitive functions, emotional functions, and eye movement. And what you'll notice then in these patients, each one of these different areas are impacted. You'll see choreiform movements in some patients, procedural learning, difficulty learning, maybe a regression in school, cognitive dysfunctions you'll see where maybe brain fog or inability to think, emotional functions with rage, anxiety, etc., and even mydriasis in the eye movements. So let me briefly go to the nomenclature because this sometimes can be a little bit challenging in the sense that we mentioned pandas. It refers to streptococcal infections, whereas it is also known that other microbes do bring on and can elicit these same symptoms, and also environmental and other biological factors. So we know that there are infectious triggers and non-infectious triggers. And the attempt was then, when PANS was coined, to be pediatric acute onset neuropsychiatric syndromes. Well, it's irrespective of strep, it's irrespective of the organism, but what happens if you're not a child? Well, you can't have PANS and you can't have PANDAS, but you may have the exact same syndrome. And therefore, different terminology has come up, like ANDL, which sometimes refers to adult neuropsychiatric disorder associated with Lyme or autoimmune disorder associated with Lyme. But in reality, what we do know is these are things that we might think of as autoimmune encephalopathy or encephalitis, although encephalitis tends to be a connotation of a direct infection, but it could be either, but we're not talking about a direct infection on the brain. Sometimes you'll see it referred to as basal ganglia encephalitis. But at the end of the day, regardless of your age, regardless of the triggering organism, it's an immune dysfunction that results in neuropsychiatric and behavioral symptoms that is triggered by an infection. So, lo and behold, autoimmune neuropsychiatric disorders that are triggered by infections aren't new. So back in the 1600s, Thomas Sydenham described what he called chorea minor, or what then was known as St. Vitus's dance. And this was abnormal movements, the loss of fine motor control, loss of emotional control. Again, remembering what the basal ganglia is biologically responsible for. And Sir William Osler described in the 1800s this bizarre and precipitate behavior in children with chorea minor and Sydenham chorea. And it is known that it is the causative agent of group A streptococci, but it's also associated with rheumatic fever. About 30% of individuals who have rheumatic fever also exhibit Sydenham's chorea. Now, in the US and in many areas around the world, we don't see that as frequently, but with post-COVID and more infections with strep, we're starting to see more of Sydenham chorea. So the challenge for you and your patients and those that are dealing with or suffering from an autoimmune neuropsychiatric disorder that's secondary to infection is the difficulty in generally others understanding how this occurs. So let's ask the question, why do certain infections trigger these immune-mediated neuropsychiatric disorders? So what's the biology behind this? I shared with you the process or one of the processes, but what is it that it's about them that actually triggers this? So we do find, not only in our studies, but also in others and what people are seeing who take care of these patients, there's a list of bad actors that typically show up. And these include strep, obviously, for pandas, influenza, chickenpox, mycoplasma, Lyme, and other tick-borne disorders such as Babesia, Bartonella, even Coxsackie virus and others. And even there's reports of SARS-CoV-2 triggering this. So why do these certain infections have some type of association with that? Well, let's go back to molecular mimicry and how does this lead to autoimmunity? So molecular mimicry is really just the process that goes on when some sequence is similar to a foreign sequence of, let's say, an infection, but it results in the activation of the immune system so that they can't tell the difference from one to the other. And the underlying biology of it is that we know that there are only 20 letters of the protein alphabet that we use. There are some non-native peptides, we won't go over that, but basically 20 of these letter protein alphabets that make up the sequences of all of our protein biology that's used for our enzymes, our different proteins, everything that's in our body that has a proteinaceous nature. However, in some areas, these are sequence comparisons. In a protein, let's say from a strep bacteria or from a mycoplasma bacteria, there will be a string of letters or sequences in which they are identical. Normally, the body, through our own system that identifies self and non-self, will shut those antibodies down. So how does that occur when it goes awry? Well, these are called epitopes, these strings of antibodies, or excuse me, these strings of peptides. And these epitopes typically are these peptide sequences that are used and often made with vaccines to simulate certain types of immunity. Well, if a bacteria has a certain epitope that is identical to, let's say, a neuron, and we make an antibody directed to that particular epitope, what's going to happen biologically that later it will cross-react with the neuron because it has the same target epitope. This is what we call molecular mimicry. You may begin to hear more about this because we see this with Guillain-Barré syndrome and many of the other types of disorders that occur. But there is molecular mimicry between streptococcal bacteria and self-antigens. And some of this has been published by Dr. Cunningham and the researchers that are part of what we do here. And we see that the molecular mimicry is directed towards the proteins in the heart valves, proteins in the basal ganglia, as I mentioned, and then affects joints, kidney functions, and other parts of the body. So you can see these chronic disorders that are being triggered through an infection that the immune system is actually cross-reacting with other parts of our body. This is not new and not unique to neuropsychiatric disorders, but in fact, it's been published and shown that many other disorders, like Guillain-Barré syndrome, due to an infection with Campylobacter jejuni, I mentioned Sydenham chorea with group A strep. Now we see more and more connections between EBV and lupus, MS, myasthenia gravis, and several others. So this is not new. It's something, though, that has been around, and it is in susceptible individuals. So we're going to end with molecular mimicry here. It's basically just the inability to distinguish what is self and what is non-self due to some we won't go through, but the genetics that are involved in MHC complexes and HLA complexes that actually help us distinguish between self and non-self. So let's talk about case studies for patients and the therapeutic categories that have shown clinical effectives when you do see patients with these immune-mediated disorders. So this is one of a 16-year-old female that began with some severe obsessive compulsive disorder, motor tics, and restricted food intake. At age 11, she started having this food restriction, and sometimes it can be confused with anorexia in the sense that this is actually an obsessive compulsive disorder, meaning a fear of food contamination, a fear of choking, a fear of throwing up, versus a body dysmorphia or an image issue. She had tics, choreiform movements, a whole host of different types of symptoms. And unfortunately, this particular case prompted 6 calls to the police because she got so aggressive. But we tested her. We found that one of the 5 targets, which is why we look at 5 targets, is this calcium calmodulin protein kinase 2, which is actually a stimulation assay for human brain cells. And we find that she was highly elevated. And her illness was she had relapsing remitting symptoms, 3 major episodes, and increases symptoms after exposure to strep. She did have autoimmune diseases that were not otherwise specified. She was diagnosed with post-infectious encephalitis and other diseases, but the lab results revealed that she actually was suffering from Lyme, mycoplasma, and Coxsackie virus, which is what happens sometimes when we have clinicians will get a positive test here. They'll look for these certain typically identified organisms that have not been treated or maybe or appear to be subclinical. So the family history actually was helpful because they had autoimmune disorders in the family and rheumatic fever and siblings with pandas. In this case, she was treated with plasmapheresis to remove the antibodies and intravenous immunoglobulin, and to control some of the symptoms for a short period of time, low-dose Zoloft and Abilify. And she was significantly improved after the treatment, and she was retested and showed that all of her target antibodies, specifically the CAM kinase, returned to baseline. This is a 17-year-old young man who had multiple neuropsychiatric symptoms. And what I want to show here is pre and post that this young man had an abrupt onset of OCD, couldn't concentrating, handwriting disturbance, etc., and relapsing and remitting symptoms, panic disorder, etc., high Coxsackie virus, HHV titers, chronic sinusitis, and frequent viral infections, positive for rheumatic fever. So the treatment was NSAIDs and multiple IVIG infusions. And what you can also see in this patient also, a single CAM kinase activation, and the treatment improved significantly with anti-inflammatory drugs and IVIG treatment. This is a 8-year-old young girl who had numerous psychiatric symptoms, abrupt onset of OCD, emotional ability. She began to wet her bed, sleep problems, which is not uncommon with disruption in this part of the brain. She had a lysoganglioside GM1 positive and a tubulin positive. She had relapsing and remitting symptoms, anxiety, OCD. She also then, interestingly, was negative for ASO, anti-DNase B, and normal IgG titers. So one thing that they weren't able to find is what is the underlying infection, at least in this particular lab result. Maybe it wasn't strep, or strep can be found in other orifices of the body. But they did find that it was significant for 2 recent streptococcal infections, and she had a history of frequent ear infections, sinus infections, and idiopathic fever. So the family history was positive for mycoplasma infections and autoimmune disorders, Allergies, frequent bacterial and viral infections was a signal there. So this patient was caught early, and this was the nice thing about the testing, is the patient was treated with one course of azithromycin with a rapid symptom improvement. Because in this case, most likely the B cell, the long-term B cell activity may not have been activated long enough such that you remove the underlying trigger that in this case, all her symptoms were resolved, returned to baseline, and as you can see, her lysoganglioside and antitubulin were returned back to normal. So let me just quickly give you a couple more. This is a 20-year-old young girl with gradual onset. Now, pandas and pans, this would be beyond a pediatric child. So gradual onset is different from acute onset, in which is one of the criteria for that. But sometimes these onsets of OCD and others may be a single symptom, or they may not remember that there might have been some kind of onset. But this makes it a little more difficult to try to identify a patient and diagnose a patient. And we saw that she had a dopamine D2 positive and a CAM kinase positive. So same thing, relapsing, remitting, frequent flares, idiopathic neuropathy, positive for Lyme disease and other disorders of the autonomic nervous system. So positive for strep, positive for babesia, mycoplasma, Epstein-Barr, herpes zoster. The thing that is important is often we see more than just one infection in these patients. And this makes sense because if the immune system is compromised, then you've got these other opportunistic infections that come in. And therefore, it even makes it more challenging to get the patient well, because until you find these and you treat these, often they're still stimulating the immune system. So there was frequent strep infections and low IgG, dental infections, positive history for autoimmune disease. So this one was a challenging case because it required the treatment of rituximab, which rituximab will remove basically the majority of all the B cells. And once that was done, she had a significant reduction in all of her symptoms. In fact, you can see the dopamine D2 returned to baseline, the calmodulin CAM kinase returned also to baseline. So let me share one more. This was a published case with Dr. Bernstein, an immunologist at Cincinnati Children's Hospital. He identified a 15-year-old young girl who originally was diagnosed with schizophrenia, psychosis, severe anxiety, and she was in and out of treatment facilities several times. They were unable to contain her, and so they were getting ready to put her back in the treatment facilities. They brought in Dr. Bernstein, who's an immunologist. He knew about the panel, the autoimmune brain panel. He in the published study showed that she had elevated levels of dopamine D1, D2, lysoganglioside, and tubulin, which is why we have to run all 5 of these, because different symptoms correlate with different positivity of these antibodies. What he said was that after one course of plasmapheresis was administered, the patient had complete resolution of her psychotic, OCD, and anxiety symptoms. She was weaned off of olanzapine and resumed many of her normal activities, including tennis, within 2 weeks after plasmapheresis, and the response has been sustained over 6 months. We read the study, we contacted him, asked him for a sample that we could test post-treatment. We ran that, and all of her antibody levels were back to normal. I think this is an important thing to remember, because there are many tests out there that either purport to identify certain types of targets, but they have no clinical validation or clinical utility being demonstrated in use. There's a lot of different ways to test for certain types of targets, and the problem is that they actually can present in different sort of configurations, different processes that are used, and you don't get the same results. So the most important really defining evidence is to look, is there clinical validation? Is there treatment studies? is there independent validation of its utility in showing that? And I think that's the important thing in medicine, because there are certain things that can be done that look like maybe a similar type of testing, but they don't actually have the same results. So it's important to be able to have data to show that whatever testing you're using and the decisions you're relying upon to treat your patients have been clinically validated. So over the 20 years of research and all of these 16,000 now patients, what we have found that when an antibody against dopamine D1 is found in a patient, we see these psychiatric clusters, such as psychiatric symptoms, mood swings, depression, irritability, etc. And a paper just got published with Dr. Cunningham and her work showing that when patients have antibodies against dopamine D2, you see movement clusters. Patients have some type of choreiform movement, some type of maybe inability to sit still or hold still, and maybe then as a result, a diagnosis of ADHD. When there's antibodies against lysoganglioside, GM1, we see tic clusters, patients frequently complaining of also joint pain, connective tissue pain. Tubulin, though it's a common protein, but it's highly concentrated in the brain, is another marker that tells us when we see positives against tubulin, the patients typically will complain of brain fog and present with obsessive compulsive disorders, maybe food phobia, clothing, intrusive thoughts, etc. And this is a unique assay that's a radioisotope assay in which we grow human brain cells, not the patient's brain cells, but human brain cells in culture, and we incubate their serum on, because we're looking not just for binding, we're looking for whether or not these antibodies will stimulate the activity of this particular enzyme. So why is that important? Well, this enzyme is responsible for upregulating neurotransmitters, dopamine, epinephrine, and norepinephrine. And so this is another important feature, as you saw in some of the tests, that this was the only one in some cases that were positive. And patients with positives with the CAM kinase will demonstrate sympathetic nervous system activation, such as anxiety, easily startled, mydriasis, fight or flight behavior. So these are the associations that we typically see with patients that are presenting with these different types of disorders that are positive. If you'd like, there's multiple research papers that we can send to you. Patients with persistent Lyme disease, treatment with immunoglobulin in some patients who were diagnosed in part with autism, but suffering from an immune-mediated component. You see things with different types of hands and pans. And so they're on our website, or we'll be happy to send these to you. We have lots and lots of these. So the goal of precision medicine is really to take patients presenting with heterogeneous symptoms caused by different underlying reasons and separate them into categories in which they are either immune-mediated or they're not. And in this case, then, patients that are immune-mediated can be treated with immune modulators, anti-inflammatory, anti-infective agents, and anti-infectives. The great news, excuse me, my allergies are acting up, is that we have hundreds and hundreds of stories of patients such as Grace. This is a young girl who was diagnosed with a mental disorder at 8. She was trying to kill herself. She had OCD and ADHD, oppositional defiance. They had found out about us. We had tested her. The treatment was changed. And not too long ago, her mom sent us this picture of her completely well, back to normal life, and on the cheer team doing well. Adam, who was diagnosed with ADHD, they thought he had autism too, and they were considering putting him in an institution. They found out about the testing. Their doctor ordered the test, and then Adam fully recovered. And not too long ago, his mom sent us this picture of him running cross country. Said recovery is possible. He's 10,000 times better. We have hundreds and hundreds of these stories, more of these case studies. Our goal is to continue to publish these, show the utility, and be able to provide a resource that will help you as you identify and diagnose patients with chronic disorders. So what are the common symptoms? So what do we see commonly when patients are positive in the autoimmune brain panel? Well, generally we see that there's some treatment resistant to standard neuropsychiatric drugs, which is one tip-off. The other is they may have frequent infections. Sometimes this can be subclinical, and they could be diagnosed with post-treatment Lyme or PANDAS and PANS. Family history of autoimmune disorders is one condition we see often. Sudden, rapid onset of these neuropsych symptoms, rapid onset of OCD, and again, a restrictive eating disorder that's really an OCD rather than a body dysmorphia. Vocal, motor tics, choreiform movements, anxiety, rage, separation anxiety, emotional ability, depression, developmental regression. Dilated pupils may be in about a third of these patients. Urinary frequency, bedwetting, relapsing remitting, and suicidal ideation. One of our pediatric neurologists says that every single patient of hers that are positive, that are fit into these categories, if you ask them, they will tell you that they do have thoughts of suicide, but you have to ask them. And so this is an important reason why we do need to identify these patients early on. And of course, PANDAS and PANS diagnosis. So what are some of the takeaways here? One, it's important to get a thorough medical history because you're looking for signs and things that could tip you off as to that. And then this gradual onset might really have been a sudden onset many years ago. Relapsing, remitting, family history of autoimmune disorders, restrictive eating disorders, obsessional fears, and the choreiform movements. One of the physicians that we work with says if you have the patient put their hands out straight, close their eyes, have their hands flat, watch and see if their fingers start to move as if they're playing the piano. Dysgraphia, motor tics, vocal tics, mydriasis. And then some labs you can check for strep, DNA-SB, ANA. Many of these different ones, but the one that really and we're talking about today is how these targets are associated with the autoimmune brain panel. So maybe we can sum this up of the treatments. What you're really looking at, identifying, once a patient has been identified, be sure you look for all the infections because usually they're more than one. Treat the inflammation because the infection is triggering inflammation, and then treat the immune dysregulation in some manner and provide symptomatic relief as necessary. And we'll talk about these in the 3 I's. Look for the infections, treat them. Look for inflammation, treat the inflammation, treat the immune dysfunction. And what we find is you certainly should consider, depending on the length of the time the patient is ill, the metabolic dysfunction, gut dysbiosis, Herxheimer reactions when you begin to treat these. So there are many things that make it a little bit more challenging, but what our goal is to provide a tool that gives you some biological evidence. So one thing we'll wrap up with is if you're interested, how do you order testing? Well, we require that a clinician order the test in order to be able to take care of the patient. The blood tubes are sent to us. The panel price cost is $9.95 in the US. We have other partners outside of the US who do a fantastic job, and they have their pricing because of the shipping and everything else associated with it. We require a deposit internally. FedEx then sends it to us overnight, no matter if it's in the US or outside of the US. And we test these within 2 to 3 weeks. Now, that seems like a long time. It used to take 6 to 8 weeks. We're getting this down because this is not a common assay. In fact, we're the only ones in the world that run this. And then we upload the results to your portal. You'll have a portal where you can access that. We also courtesy bill in the United States for patients with medical insurance, and physician online report is available, and then treatment is available. We do have supportive consultative services. We can provide webinars for your office staff. Email us at medicalrelations@moleculera.com, or that phone number there. We also provide support, free support services for clinicians on laboratory results. You can email us at medicalrelations@moleculera.com. We have a staff nurse and a staff nurse practitioner that help you. Amy, our moderator, I've given you her email address, crossa@moleculera.com, or the phone number. We have lots of resources, publications, videos, websites that you can access. If your patient has question about blood draw or the panel or payment terms, we do have some ways to make payment terms. Call our office, and that's the office number. As I mentioned, insurance and payments, 405-239-5250. Or you can download educational brochures at our website. So we're here to help you. Our goal is to be able to help change how medicine is practiced. And what we are doing here is we hope to be able to provide resources and help for you as you take care of your patients, because we do know the pain and suffering that goes on through this. So let us know how we can help you. And that's why we're here. And that will conclude the presentation.
Thank you so much, Dr. Shimasaki. It was wonderful as always. I am looking at the questions that have been placed in the chat, and I'm delighted to see Dr. Jansen-Rossick, that both Rolf Jansen-Rossick and Nils Jansen-Rossick, I had a wonderful conversation a while back with Dr. Jansen-Rossick about our panel, and it's delightful to be able to connect with you again. He asks, how do antibodies get removed from the central nervous system?
Yeah, that's a great question. There's a couple things that we find that are associated with this. In patients, most likely have a leaky blood-brain barrier. And there's a understanding that the same endothelial lining is also the same endothelial lining that is evolved around our gut. We are exploring a couple of targets that we're looking at that would tell whether or not the blood-brain barrier is open. And we're hoping to be able to add that as a means to the panel. To get to your question, if the blood-brain barrier is open and the antibodies are present in the serum, which we test, we have tested CSF and find that they are also present in the CSF. There is clearance mechanisms in the CFS, but if you can get rid of the production of the B cells that are producing, or the reason that they're producing these, they will eventually clear themselves. And if you can heal the blood-brain barrier, you also can protect that. So what we're seeing is these supportive elements that help heal the blood-brain barrier, plus the ability to get rid of the infection that's triggering the antibodies in the serum, plus the ability to contain those or remove them, then they're eventually removed from the CNS. So it is a process, and this is why you saw the one patient who had antibiotic treatment very early on, before the immune system began to making plasma cells at least enough to be able to have constant production of these antibodies, very quick and rapid recovery, and that's our goal. So they do eventually get eliminated, but if you don't eliminate the source of it and you don't stop the reason for it, it'll just continue to be chronic.
Thank you. Another question. Are the basal ganglia the only CNS structures you see molecular mimicry with? He is asking, I'm thinking frontal lobe and other cerebellar diseases.
Yeah, that's another good question, because in fact, there are some studies and research that show that in addition to the basal ganglia targets, in some cases, in some patients that have other symptoms, yes, they're against other parts of the brain. And so there are those. I was just showing what the research that we have been able to do to show the basal ganglia targets, but it is not completely limited to the basal ganglia. And yes, we believe and do see that there are other targets, and that is something also to be aware of. And again, if you treat the root and the underlying cause, regardless of what the target is, the goal is to be able to stop that also.
Thank you. An excellent question. Do you have cases involving ADHD and autism that are linked to antibodies and resolve with antimicrobial treatment?
Yes. So one of the things that I'd mentioned, all of these different disorders are diagnosed by either exclusion or symptoms. So, and as we all know, ASD is a spectrum, and sometimes you can have comorbid different types of conditions. Dr. Fry has published a study where he did run multiple different types of autoimmune testing against autism patients that also had what he believed was potentially an immune-mediated disorder, either comorbid or independently. And what he was able to show with treatment with IVIG, at least in this case with a treatment, that these patients' autism symptoms dramatically improved. We could send you that. It would go to show probably that if you're also looking at an infection-triggered autoimmune condition, that antimicrobial treatment would also and could also be effective. And we do see that in individual patients. As mentioned, some of these individual case studies, Adam, for instance, had a diagnosis of autism. So the key also is to identify what are the underlying causative infections, because it could be viral, could be bacterial, it could be parasitic.
Next question is a participant asking if they will have access to the slides.
What we will do is send out a copy of this video with that on that, because some of this data in the slides are in preparation for manuscripts. We don't send those out at this time, but you will have the video with the slides gone over in the video, and then it'll be broken down into the timestamps. But because it's much of the data, some of the data that I presented is actually going to be prepared for manuscripts that we don't, because it would nullify our ability to publish the work.
A question from our friend Dr. Suzanne. Have you any clinical models for treating this that use natural, non-drug-based therapies, especially if plasmapheresis or IVIG are not options? She knows of a case where the patient is so sensitive that she refuses to let anyone touch her, and energy is so low that she cannot leave her bed.
Mhm.
Haven't we?
Yes, and in fact, let me start by a little background. There's probably maybe 20 to 30% of the formulary for medications that are still originated from natural products. So all the NSAIDs are from the willow bark, which started with ASA and that, the foxglove and digitalis, the opioid poppy and all of the narcotics, many of the cancer drugs. So the point is that the answer is yes. Now, what are they? There are many of them, and there are many practitioners who are becoming very well versed at using these let's say, FDA drugs and having some really significant effect. So there are many of them. And so the answer is yes. And I do believe that either with or in conjunction, or some cases where you need to, alternatively, these can and have, we've seen effectiveness. So it's important to recognize that and then find those that have done that and use these, because I do believe that they are effective also.
And Dr. Shimasaki, a final thank you from Dr. Jansen Rosick. We appreciate all of our participants today. You will receive a link to the recording in a few days. And by all means, please do let us know if you have any questions at all. We're here to help. Thank you. Thank you,
Amy,
Dr. Shimasaki.
thank you, Amy. Let me add one other last thing. We have some fantastic international partners. ALM is the one that works with us in Europe. And we also refer to them. So if you have any questions and you are here from out of the country, we certainly can put you in touch with AONM and be able to leverage and use them in your interest and support of what you're doing. Thank you, Amy.
Okay. Well, thank you so much. Oh, I see one more question. Says, I am sorry, but we would have tested hundreds of patients. Unfortunately, the panel is not covered by insurance companies. I have closed my private clinic at the end of 2024, but his son has just opened his medical center south of Berlin, focusing on ADHD in adults. He is a neurologist, psychiatrist, and psychotherapist. We would be delighted to cooperate with you and find a way to test more patients. Is there a chance on a scientific basis? And we'd like to explore that a bit more. So Dr. Jansen-Rossick, let's arrange a call very soon. So we can discuss how best to partner.
Absolutely.
Yeah.
Yep.
And thank you, AONM. Thank you, Jillian, very much.
Mm-hmm. I know.
Bye-bye.